What about hospitals? Now, hospitals are big fixed cost institutions. You know what the big difference is between hospitals and doctor's offices? Anybody want to know what the big difference is? Hospitals are open 24/7. We expect them to be there 24/7, not the doctor's office. We expect the hospital to be there no matter whether they have patients or not. They should be there staffed and ready to go in case somebody needs something. When there's a big accident on the freeway, when there's a flu epidemic, we expect them to be staffed and ready to go for that. Now, in some ways you'd say, well, maybe it's not surprising that hospitals then are actually the biggest and fastest growing piece of costs. More money, top bar is hospitals. Fastest rate of growth during the last decade was hospitals. So if you're going to do something about healthcare costs, you've got to do something about hospitals. That's where the money is. But let's look at the economics of a hospital. So I'm going to take some hypothetical hospital service line. Cardiac care, orthopedics, whatever it is. But I'm going to say, so the hospital invests a lot of money to be able to give good quality care. They have to have a surgery suite. They've got to have all that equipment that people expect them to have, the MRIs, the robotic surgery, whatever it is. So let's assume that they spend $6.7 million to equip this particular part of the hospital. And it costs them, variable cost, $3,000 per patient. So every time they get a patient, they have to spend $3,000 more. So it may be for the hip implant, it may be for the stent, it may be for the thing, but they don't spend those things unless they get the patient. And let's assume that they get paid $10,000 per patient to do whatever it is that they do in this particular part of the hospital, the hip surgeries or the stents or whatever. So if they get 1,000 patients come in the door, what are their costs going to be? Well, they have that $6.7 million in fixed costs that they have, plus they spend an extra $3,000 for every 1,000 patients. So it'll cost them just under $10 million to serve those patients. They'll get paid $10 million, $10,000 per patient to be able to serve those patients. So they make a small positive margin, 3%. Good news for the hospital, right? Now, notice most of the hospital's costs are fixed. They're not going to change depending on how many patients they have. So what would happen if they got more patients? If they got 1,200 patients, their costs would go up, but their costs wouldn't go up by 20%. Their costs would go up by that variable cost, the $3,000. The cost would only go up a little bit above $10 million. Their revenue, though, we pay per patient per procedure. They would get $10,000 more for every patient. So guess what? They suddenly have a 14% margin. Really good news for the hospital. Now, what if we convince the hospital that they shouldn't do as many procedures? What will happen to their costs? Well, their costs will go down. So if the number of patients goes down by 20%, their costs will go down, but their costs won't go down by 20%. Still at those fixed costs they've got to pay for. Costs will go down somewhat. Revenue, though, will go down by 20% if there's 20% fewer patients. So what happens to the hospital's margins? They're in the red. So from a hospital's perspective, it's not a good thing to have fewer patients because that's the equation. When the number of patients increases, revenue goes up faster than costs. When the number of patients goes down, revenue goes down faster than costs. Is it any wonder why hospitals are a little concerned about us keeping patients out of the hospital? And in fact, it's really pretty dramatic. If you get 2% more patients, in my little hypothetical example here, the amount of contribution margin you're getting goes up by 50%. If you get 2% fewer patients, it goes down by 50%. Now, this is a significant slide to focus on for just 1 second because it means that you can move a market with a very small change in patients. You don't have to move all of your patients. You only have to get a small number of patients to decide to go someplace differently to make a hospital pay attention. Now, the dirty little secret of healthcare is that hospitals don't make 3% margins on their procedures. For a lot of their procedures, they make very big margins. So this chart, the left side, the purple bars are the costs, the right side are the revenues. And for some service lines, like cardiac services and oncology and other things, hospitals make very big margins. The reason why they make those very big margins is because for some other service lines, generally maternity care, mental health, other things, they actually lose money. Why do they lose money? Because they take all comers. That's the number 2 reason why hospitals are different than physicians. They take everybody. We expect them to take everybody. But some of those people can't pay. Some of those people get covered by Medicaid. Some people get covered by Medicare, which pays those low rates. So they end up having to charge you more for the things that your patients get, your employees get, to be able to make up the rest of the money. So no wonder the hospitals are concerned about losing some of the procedures that they actually use to subsidize all their operations. And the final piece of this little economics lesson is the so-called hospital-physician alignment. So let's take colonoscopies. Everybody should be having a colonoscopy every 10 years over 50. Has everybody had their colonoscopy? So there's two places you can get a colonoscopy. You can go to a gastroenterologist's office and get a colonoscopy, or you can go to a hospital outpatient department to get a colonoscopy. How much does Medicare pay for those things? They pay the physician $400 if they do it in their office. They pay them $220 if they do it in the hospital. Now you'd say, wait a minute, I thought the hospital was more expensive. This is how much the doctor gets paid. And the reason why the doctor gets paid more is because the doctor's fee is covering not only the doctor's payment, but all the costs that they incur along with that. When they go to the hospital gets paid separately for the colonoscopy. So guess what? It actually costs twice as much to get your colonoscopy in the hospital. Now, does a colonoscopy need to be done in the hospital? Nah. But think about this. So if the hospital is getting paid twice as much to do the colonoscopy as the physician is, do you think the hospital might be able to pay the gastroenterologist more to come work for the hospital to do the colonoscopies there? Where they could then maybe draw in some anesthesiologists to do some work too, et cetera? So that's the problem, is that because of the way we pay, hospitals can actually pay physicians more if the physicians come to work for the hospital than if they stay independent. So not surprising that we're seeing a lot of people ending up working in hospitals, because the hospitals actually can take all that extra money that they're making and pay them. So those are the problems with the fee-for-service today. We don't pay for things that actually are high-value care. We don't pay for phone calls when a patient has an urgent need. We don't pay for emails. We don't pay for nurses. We can't move the money around between the silos. And people get paid less whenever they actually do the things that we ask them to do, which is to prevent complications, infections, and do fewer unnecessary procedures. And they don't get paid at all when the patient stays healthy. Now, people nationally have finally started to recognize this, that there is a problem with the fee-for-service system because of that fact. But people aren't really fixing that. What they're trying to do with payment reform today is they're giving these little itty-bitty pay-for-performance bonuses, or these little itty-bitty per member per month payments, or little itty-bitty shared savings payments, on top of what is still fundamentally a fee-for-service system. Now think about it. If you're getting paid that much fee-for-service and somebody gives you a little pay-for-performance bonus, who's mama? It's the fee-for-service system. So fortunately, though, there are better payment systems available. So there are ways to pay those primary care physicians in a more flexible way, but to give them accountability for the outcomes that they can take accountability for. There's a notion of bundles and warranties to be able to give people flexibility but accountability for the procedures they do. And there's a notion of a condition-based payment, which is actually what patients want, is to have their condition treated, not necessarily to get lots of tests and procedures. So why not pay based on the condition rather than the procedure? And the good news is that these true payment reforms, not these tweaks to fee-for-services, true payment reforms actually allow a win-win-win. They allow better care for the patients, less spending for you, and the providers can actually do better. Let me show you how. So every other industry in America gives warranties, right, except healthcare, you'd say. Not possible in healthcare, right? Well, in fact, the Geisinger Health System in Pennsylvania has been doing this for a number of years now. They didn't call it a warranty. The New York Times called it a warranty. They call it proven care. But basically, it's a single price for everything that happens during a person's hospital care, including what they get after they leave the hospital and any related complications or readmissions that they have. And they started doing this with cardiac bypass surgery, and they've been systematically expanding it ever since to maternity care or low back pain, things that don't even necessarily have to happen in a hospital. What happened as a result of this? Well, these are their results for CABGs, bypass surgery. Not little itty-bitty statistically significant improvements. They got 20, 40, 60% reductions in complications, infections, and readmissions quickly in 18 months at a place that was already had a reputation for being a high-quality leader. How'd they do that? Because no longer were they being paid for doing things, they were being paid based on the outcomes. And they had the flexibility to decide what they could cut out to be able to do that. And guess what? They were able to use this to actually give reductions in premiums to employers in the community. So that in fact, this is a story about how teachers were able to get a raise because their premiums went down. Now the myth that is developed is you have to be a Geisinger health system, a big integrated delivery system with employee docs and your own health plan to be able to do this. The earliest documented example in healthcare of anybody giving a warranty was a single doctor in Lansing, Michigan, orthopedic surgeon, shoulder and knee guy, said, I'll give a 2-year warranty. Anything goes wrong, I'll fix it free of charge. It's in the literature. Health plan paid less, doctor made more money, hospital made more money, patients were better off. Why? Because they didn't have to do things based on the fact that what they were going to get paid for, they could focus on the outcomes. But it does take somebody to pay differently to get there, and I'll come back to that. You can't just do this on your own. Now, to understand this, first of all, warranty is not an outcome guarantee. You're not guaranteeing the outcome of the surgery or the procedure. When you buy a car with a warranty, nobody's guaranteeing you that your transmission is not going to break. What they're saying is if the transmission does break, we will fix it free of charge. And most warranties are limited warranties. They don't cover absolutely everything because not everything is preventable. But the other thing that's a mind bender lots of times for employers is that you would have to pay more than you do today for warranted care in healthcare per procedure. Now you'd say, but wait a minute, I thought I'm trying to save money here. Well, think about it though. In any other industry, when you buy a product with a warranty, would you expect to pay more for a product with a warranty than a product without a warranty? Of course you would, because you would expect that then you didn't have to pay for all the repairs. You might not be buying the Best Buy extended warranty, but if you were buying a product that had a warranty came with it. So let me just show you an example. Quick example. So let's assume the hospital is doing a procedure. They get paid $25,000 for it. They have a 10% readmission rate today. 10% of people come back to the hospital in 30 days. And they get, when they come back, the hospital gets paid an extra $25,000 every time they do. Now, if you're paying for this care in the hospital, you're not paying $25,000 per procedure. You're paying $27,500 per procedure. Because when it goes well, you pay $25,000, and 10% of the time, you get stuck with an extra $25,000 bill. So on average, it's $27,500. Now, if you were this hospital and you wanted to offer this procedure with a warranty, so you say, I'm not going to charge anymore for the readmissions. If they happen, come out of our money. How much would you charge for this procedure? Well, the answer is you would charge $27,500. Because if you charge $27,500 per procedure, you would be getting exactly the same amount of money that you were getting before, because you wouldn't be getting paid extra for the readmissions. So why would you do that? Well, the answer is because all the incentives have changed now. Because if this hospital can actually reduce the readmission rate from 10% to 8%, their costs will go down because they don't have to take care of those patients anymore on the readmission. But their payment won't go down. So they'll actually make more money. But we want to save you a little bit of money in healthcare, right? So this hospital can now come to you and say, I could actually now charge less than I was charging before, or have you spend less than you were spending before, and I could still make more money. And this virtuous cycle continues because if the hospital can keep driving down the readmission rate, their costs will go down, but their revenue won't go down in proportion to that, and they can continue to offer that at lower prices. And so in the end, you have better quality, lower readmission rates, better for the patient. You have lower prices, how much you're actually paying for the care, and the hospital is coming out ahead. Their margins are higher. Win, win, win. But it's because you're paying differently. This is actually aligning the financial incentives and the quality incentives.